You ever been told that someone from a doctor's office or some other program would call you back, and then just crickets? Nothing? Yeah. Today, we're diving headfirst into that incredibly frustrating void, the referral black hole, and more importantly, how we can actually seal it up for good.
It always seems to start with these few simple words, doesn't it? A patient puts their trust in the system, they go home, and they wait. But what happens when that phone just never rings?
And look, this isn't just some made-up story. This is a real example from our source material. A person in desperate need was promised help with food and medicine, but because that help never came, they ended up right back in the hospital, even sicker than before. The stakes here are literally life and death.
So that's the big question we're tackling, right? How does a clear, direct order for help just vanish into thin air, leaving a patient completely stranded? Let's unpack how this happens and then get into the solution.
Okay, so what's the fix? Well, the antidote to this whole problem is a concept called closing the loop. It's a really deliberate, systematic way of making sure that no patient, absolutely no one, gets left behind.
Now, the official term for this kind of work is care coordination. And it's so much more than just handing someone a phone number and saying, good luck. This is about organized teamwork, making sure a patient is actually connected to the clinic, the pharmacy, the food bank, all the different pieces they need.
And the real hero of this story? It's often the community health worker, or CHW for short. You can think of them as the human link in the chain, a trusted guide who really gets both the healthcare system and the community. They are the ones who make sure these connections actually happen.
So what does a good, solid, closed-loop referral actually promise? Well, it really boils down to these three simple but incredibly powerful commitments. First, there's accountability. Someone is responsible. Second, there's transparency. No more mystery about what's happening. And third, there's a real, documented result. No more guesswork.
And I love this because it sums up the entire goal in one perfect phrase, the no dead ends rule. It's a super clear principle that says every single referral has to lead somewhere with a known outcome. It can't just disappear.
So, how do CHWs actually put this no dead ends rule into practice, in the real world? Well, there's a playbook for it. Let's walk through the 7 essential steps they follow to make sure the loop gets closed every single time. So here it is, a practical 7-step workflow. It starts with the patient, clarifying what they need in their own words and getting their okay. Then the CHW does the legwork, verifying eligibility, submitting the referral. But see, the crucial part is in the middle, proactively tracking the status, not just waiting for a call, and then actively helping the patient with any roadblocks. And then finally, the loop is officially closed when the outcome is written down and reported back. It's a complete, active process from start to finish.
And check out how step 1 is framed here. It's not just, so what's your problem? It's a deeply patient-centered question that gets right to their most urgent need. That's how you build trust from the very first minute.
And right here in step 5. This is the total opposite of that story we started with. The CHW's job is to be proactive. They don't just send a fax and hope for the best. They are actively on it, following up on a schedule. They are the ones making the call.
This just lays it all out so clearly, doesn't it? A cold handoff puts all the work, all the burden on the patient. But a warm handoff, which is at the very heart of care coordination, is about partnership. It says, hey, we're in this together, let's do this.
Okay, so this whole process sounds incredibly effective, even like a game changer, right? So that leads to a pretty big question. If we know this works so well, why isn't it just the standard way of doing things everywhere? Well, the answer gets into a classic problem: bureaucracy, paperwork, and policy.
It really all comes down to something that sounds boring but is absolutely crucial: getting paid. For CHWs to be paid for this work through programs like Medicaid, the service they provide needs a clear, standard, billable definition. The huge problem? At a national level, one just doesn't exist.
I mean, just look at this example from Minnesota. The law's on the books. It says it's supposed to cover this work. But because the actual definition of care coordination got kicked down the road for more study, the only thing CHWs can actually bill for is patient education. All that crucial follow-up, the navigation, the warm handoffs, it's all left unfunded.
And because there's no national rulebook, you get this: a total patchwork of different definitions all across the country. As you can see, Arizona, Iowa, California, Louisiana, they all describe it a little differently.
One calls it being a liaison, another calls it health navigation, another proactive engagement. They're all getting at the same thing, but the language is all over the place.
And what's the result of everyone playing by slightly different rules? It creates huge roadblocks for getting consistent funding, for developing training programs, and for scaling this work up. It basically keeps a proven solution stuck in small pockets instead of helping everyone who needs it.
But let's be clear, this isn't just some boring policy debate about words on a page. This definition dilemma has a massive human impact, especially when we start talking about health equity.
Because true care coordination is what equity looks like in action. It's about building trust, especially with patients who've been ignored or disrespected by the system before. It's about the simple things like confirming language needs, honoring cultural practices, or understanding the real fears someone might have. It's about designing a process for actual human beings.
And listen to this question. This is so powerful. This is a script for building that trust. It acknowledges that harm may have happened in the past, and it gives the power back to the patient to say what they need to feel safe now. That's what real, culturally sensitive care actually sounds like.
So at the end of the day, that's what this is all about. Care coordination transforms a referral from just a piece of paper into a real human connection. It's about making sure the systems we build to help people are actually usable by the people who need them the most.
Which leaves us with this one last kind of frustrating thought to chew on. We have the playbook, we have the people who can do the work, we have the proof that it works, we know how to guide patients through the maze. So the question we have to ask is, why are we still handing them a map that's so ridiculously hard to read?
Thanks for joining this explainer. The research and insights we talked about today came from the great work of the Network for Public Health Law and from practical CHW training guides. It's pretty clear that if we want to fix the system, getting our definitions straight is a critical first step.